Timothy Albertson, Chapter 5, Positioning Project, External Shoulder. I escorted the patient into the radiography room. I asked him his name and date of birth. I then asked him to remove any artifacts that could compromise the X-ray images. I then verified the body part of interest and asked if he could perform specific arm movements with as minimal pain as possible to give me a better avenue of approach and positioning for successful imaging. I then donned the lead apron for his safety shielding. For IR size, I chose a 10 by 12 image receptor, and I placed it centered in the wall bucky portrait-wise. For SID, I set the source to image receptor at 40 inches using the digital screen on the CR tube and verified the distance with the tape measure attached to the central ray. The patient is standing erect, positioned in front of the wall bucky, with his posterior side facing the wall bucky. And we put a slight rotation toward the side of interest to place the shoulder in contact with the wall bucky. For part positioning, the scapulohumeral joint is centered to the IR, slightly externally rotated arms until his epicondyles of the distal humerus are parallel to the IR. The hands are supinated. The greater tubercle is seen in full profile. The CR is positioned perpendicular to the IR, directed 1 inch inferior to the coracoid process, with a 90-degree angulation. The CR is centered 1 inch below the coracoid process. The upper and lateral borders are about 1 inch above the shoulder and 1 inch lateral to the shoulder. The medial border is at the medial portion of the clavicle. Inferior border is just below the inferior angle of the scapula to get the entire scapula in the image. The marker is placed just outside the shoulder, close enough to view but not to impede on any bone structure in the picture. In this case, the anatomy of interest is the right shoulder. KVP range for the patient is 70 to 85 KVP. Instructions to the patient was hold still, stop breathing. I then took the picture and told him to breathe again. The anatomy demonstrated the AP projection of the proximal humerus and lateral 2/3 of the clavicle. The upper scapula is including the relationship of the humeral head to the glenoid cavity. Pathology best demonstrated and clinical indications of this photo are fractures or dislocations of proximal humerus and shoulder girdle, calcium deposits in muscles, tendons, or bursal structures. Degenerative conditions, including osteoporosis and osteoarthritis, can all be seen in this portrait.